David, I thought today we would focus on your favorite topic.
Which one is that?
Well, I know you enjoy proposed regulations and responding to them and sort of coordinating a response and sort of spending your weekends reading proposed regs. Is that okay?
I thought we were going to talk about new Star Wars movies, but yes, that's okay.
Okay. So the Centers for Medicare and Medicaid Services has sent out a proposed rule. I'll just read the title so that everyone has it. It's the End-Stage Renal Disease Prospective Payment System, Payment for Renal Dialysis Services Furnished to Individuals with Acute Kidney Injury, End-Stage Renal Disease, Quality Incentive Program, and End-Stage Renal Disease Treatment Choices Model. Did I get that correct?
You did. You did very well with that. It is a mouthful, isn't it?
Yeah, and I think what's important is just to sort of let's first have a conversation about why proposed regulations are so important, and then we can get into some of the specifics in here. I will just for frame of reference say that comments are due back to CMS by Tuesday, August 31st. So this really does become kind of how you spend your summer as you're working with our quality committee and the ASN Council and other experts to draft our response.
Yeah, this is actually, if you're on the regulatory side of healthcare, this is actually June, July, and August are the busiest. I mean, it's not that the rest of the year isn't busy, it is. But this is the time for us that you cannot schedule your vacation. You can't schedule it in the middle of the summer. It just won't work. So yeah, no, it's a really important time. And this is a very critical program in terms of taking care of people who have acute kidney injury or kidney failure or any of those other places. We do want to go upstream in other programs, and that's great. But this is what really runs the dialysis side of nephrology.
Yeah, and maybe we'd start there, which is one of the tricks with proposed rules is to stay kind of within the framework of what the rules are trying to govern and to help sort of shape those regulations, which are then implementing existing law.
Yeah, and just to give everyone a little perspective, in the fall, we spent a lot of time thinking about what needs to be addressed in the next year. And then we go to CMS in January and February and even March and try to convince them of the rightness of our thinking, which is not always fruitful exercise. But we try, we do our best, and I think they CMS try to do their best. And then they go into really writing the proposed rules. They send them probably somewhere around mid to late April to the Office of Management and Budget at the White House, and OMB reviews them, and then they get released. Once they're released by OMB, they're sent back to the agency. The agency releases them generally in late June, early July. How long it takes to get that processed. By law, you must have 60 days to review these. And when you do that, that's really your one bite at the apple to tell them what you think. And then you get another 60 days before the final. So the final comes out right almost every year, right at Kidney Week.
Yeah. And let me ask you one more sort of operational question, just on average, or maybe just specifically for this year's set of proposed regulations. How many pages within the Federal Register do these consume?
Well, this year ESRD was small. It was just at 400 pages, but it had tremendous amounts in it. Whereas the physician fee schedule, which we're going to mention just briefly at the end, was 1,747 pages. So yeah, for all those listeners, Todd likes to make fun of me saying that I'm sitting by the pool reading regulations, which is actually not true.
So as we start to dive in, I guess one other sort of question just to frame our discussion, which is within the kidney community, broadly defined, do you think most members of the community agree in terms of what their responses are like, or is there a lot of disagreement? Or are there a couple issues that generate disagreement? I'm just trying to get a sense as to kind of the alignment since as you said, to some extent, CMS is responding to input from the community as to what they should be addressing in proposed regulations.
I really do think that this is one of those areas where the nephrologist and also the dialysis providers, they do have, they have to really have their patient's best interest in mind. And I think all the parties pretty much do. and pretty much behave well and work on trying to get regulations. We don't all agree on everything, and there's little bits and pieces we disagree with that sometimes we're just kind of like, well, that's not so much really a nephrologist call as that's maybe a provider call, and so forth. But, and sometimes the dialysis providers are kind of the same way, and they're like, well, we'll kind of see what the patients and the nephrologists think about this. But for the most part, there's a lot of commonality there. And every once in a while we find an issue that we don't agree on. But for the most part, this program is way too important to patients to play with. So everyone kind of knows that and acts accordingly.
So where would you like to start? Which part of the regulations, which issues, as we start to sort of dive into a few key areas?
Okay. Well, I am so glad you asked it that way, because this is the fun part. We're going to start with 2025. Yes, that's right. We're going to start with the year 2025. And that's, it is the reason why we're going to start there is the Medicare has made it very clear that there's a lot of what I would call general housekeeping issues around how the program is run that in some are really important. And so it basically is saying, I think what they're basically saying is, okay, we've heard you in all of these January, February, March conversations, and there's a lot of things that you want to have dealt with different parties. So let's just put them all on the table so that you can really kind of put comments in this summer about things that you think need to be adjusted. And then next year, we're going to come back out and for 2022, we're going to make a big recommendation for how things will be restructured in 2023. And that's how you get to 2025, because everything is on a 2-year cycle. So what gets implemented as new regulation in 2023 will be what you deal with in 2025. To the largest extent, not everything. So I'm not going to jump into all the weeds here. I'm just going to but our listeners will know what this is going to be like. There's a lot of discussion around the calculation of low volume and payment adjustment for some facilities, case mix adjustments, which are really important for how you're dealing with the population you're actually serving and what its challenges are. The odd man outlier payment adjustment, which is something that is a amount of money that Medicare withholds, but it's to deal with outliers in care that makes them have to pay more. The catch is in the last 5 or so years, Medicare has never hit the 1% of outlier payments that it is withheld the money for, and that's the objective, is 1% of the overall program. So Medicare has been keeping that money, and that's become a big issue because we're basically saying, no, you're not supposed to keep that money. You're supposed to keep that to pay for new services. So if you're not needing it for outliers, let's reinvest it in kidney care. So there's going to be some readjustment, particularly on the pediatric side, and they want to really look at the dialysis adjustment payment for pediatric, cost reporting for hospitals, and then the one of the issues that's become very big and was really even bigger with COVID is AKI, acute kidney injury. And that is because of the number of people who are now developing acute kidney injury in hospital stays. They always have, but whether or not they can be discharged, where they can be discharged, and what can be provided to them after they're discharged. So that will be a discussion, and there'll be a question about whether we think that they can safely be discharged to home for home dialysis. And that will be a very lively conversation with a lot of different opinions by different respected nephrologists and scientists and researchers, and we'll have to see where that goes.
So in terms of the summary you just provided, what are some of the flashpoints? You started at the end there to sort of mention areas where you think there might be disagreement. I'm just wondering if you could highlight a couple of those.
Well, I don't think there will be as much disagreement in this section that I just said, except for the last one, AKI being sent home. There are some very strongly held opinions that are different by very respectable people who are going to have to come to an agreement on what they think. But actually, I think probably where a lot more conversation will come in will be on the issue of what they've asked around the mandatory model and the mandatory model questions that they have asked the ETC, the ESRD treatment choices are that's going to be a lot more controversial.
So you've sort of teed up our next issue, which is the mandatory model. So again, for people who aren't tracking this as closely, it's that end-stage renal disease treatment choices model. So why do you think there's going to be controversy there?
Well, everyone wanted them to do some rulemaking. Since it's a mandatory model, you and I were talking about this the other day. It's a mandatory model means it's under the Administrative Procedures Act, so it has got to be mandatory. And by the way, if any of our listeners saw the federal judge throwing out the DACA lawsuit in Texas, it was thrown out specifically because the judge said that the Obama administration did not correctly follow the Administrative Procedures Act. So that can mean that everything you do is undermined. So they have to do it through rulemaking. And what they want to know are some real key issues. What are the barriers that they need to deal with on PD catheters? Since you're looking at a big increase in PD usage, peritoneal dialysis usage, according to the model. And the way in which that model is structured, it doesn't really touch on how that plays out. So we're kind of like, well, how are you going to go into dealing with that issue and to get more timely PD catheter placement? And so do you need to do a whole different model just for that? How can it be incorporated into this model, the mandatory model? And they put all those questions in there. And so, I mean, it's a pretty wide open issue. I think there will be some real discussion about, our listeners are used to trying to get patient-reported outcomes in the CAPS every year for in-center dialysis. We really don't have any quality measurement for home dialysis. And so that's really what we're going to need. Patient-reported quality measurement. So we're going to need to see how we can go about doing that. And that's actually a stickier wicket than you would think. You would think, well, that's pretty simple, but it's not. It truly is not. And nephrologists and dialysis providers do struggle with that every year about how to do that. Some of the other things they have suggested is to try to deal with a form of risk adjustment within the model and within the mandatory model, and that's not going to be easy. They didn't do risk adjustment in the beginning because they thought it was so difficult, but everyone said, and everyone pointed out, you're talking about increasing home dialysis, and not everyone has a home or the ability to be able to do that, whether they have a care provider or not. So they came up with an interesting idea, which is they want to do two things with what you consider to be the dual eligibles. Those people who are eligible for both Medicare and Medicaid. When you talk about dual eligibles as a population group, you're talking about some of the most challenged the most challenged population group out there. So this is an elderly group that is also very low income. So that is definitely a problem for people who would like to consider home dialysis. So what they want to do is they want to provide a special incentive for those individuals with those groups, nephrologists and facilities with high percentages of dual eligibles, so that if they make a movement in that category of patients, they get an even bigger bonus. The second thing they want to do is risk adjust by kind of putting a dividing line out there in the population. The Medicare population receiving dialysis for kidney failure is that the top 50% of the population that you're dealing with in terms of high dual eligibles, and the lower 50% where you have less. And they're going to use that. They're proposing to use that cutoff line to make adjustments for those who have high percentages of dual eligibles as a way to kind of deal with the fact that there's some people who just, for different reasons, they cannot do home dialysis. They have no one to help them. They live in very crowded quarters and they can't do the material. They live with multiple people in the house and they don't have the ability to do that with water and electric. There's a lot of things that get involved there. And I mean, like, for example, in Canada, they do make adjustments and provide some compensation for water and electric bills for home dialysis patients because those can be expensive.
So you mentioned home dialysis, and one of the things I noted when I looked at the proposed regs is there were a couple of sort of specific sections in there about new innovations and technologies. Before we shift to the proposed regs for the physician fee schedule, can we just I just like sort of your sort of insights around those issues?
Well, I did want to hit those too, so thank you. Our listeners may know them as either Tiffany's or Tiponies, and it depends on which group you've heard it pronounced. And that means the transitional payment adjustment for new and innovative equipment and supplies. So that is something that is something ASN fought very hard to get, and it's designed to give a boost payment for innovative devices that would probably not get taken up in the bundle if there wasn't some add-on payment. And so we have some issues. ASN has some issues over how they're making the evaluation to make that payment. And we're going to have that discussion again because it's a lively discussion even amongst ASN members. And there are two applicants out there. One is a home hemodialysis device that is asking for it, and the other one is one that deals with detecting particulates for PD, for dialysate fluid, and trying to anticipate where you might be looking at peritonitis, a sign of peritonitis being developed, which is very important. So these have been given new status by FDA, but CMS also has to weigh in before it agrees to pay for them. So this is pretty important, and this one I think is going to be shaping up with some probably legislative side to it, which gets us to physician fee schedule because that's also got a legislative side to it.
Yeah, so let's close with just a quick sort of discussion about the proposed rules for the physician fee schedule.
Well, the biggest deal for nephrologists is that they would see a 3.7% cut on what they had received from last year. And this is, or for this year, excuse me. And this is a little bit of kind of a misdirection because it makes out that CMS cut it. The truth is, last year, Congress went in and adjusted what we call the conversion factor, which led to a 3.75% increase. So what you're really seeing is that is going to expire, what Congress did. And so you're back down to your budget neutrality levels that you had before. But ASN, with others in the kidney community, have formed kind of a very kind of united group of specialist societies. And we have signed on and are asking for Congress to do a 2-year extension of that 3.75% conversion factor, which would keep the pay increase from last year on the board. So that is really that's the big piece. There's some other things in the physician fee schedule. We can get into them at another time. But that's the big one. And quite frankly, I think it actually has a good chance of happening.
Yeah, you anticipated my question. So if you were betting, your bet would be that it happens.
Yes, I would bet that it happens.
Okay. Well, I'm going to hold you to that. And I appreciate your spending your summer at the pool, going through hundreds and thousands, I guess, of pages of proposed regs on our behalf. I really appreciate it.
Actually, it's the members of our committee who really do the hard lifting, and I stand on some very big shoulders, so I have to really put credit where credit is due.
Well, I appreciate you saying that. And if people are interested, the ASN Quality Committee, all the members are listed on ASN's website, or you can just Google ASN Quality Committee. Also, David, if people want to contact you directly for either clarification around some of the proposals or just to provide their input, how should they do that?
The easiest way to do that, and I think my email is in the staff listing on ASN's the website as well. But I have an easy name. It's David White. So all you have to do is D White, all lowercase, all together, at asn-online.org. That's D White at asn-online.org.
Well, David, thank you.
Thank you.